Good morning, everyone, or good afternoon in the case wherever you may be. So I will have a voice-over PowerPoint discussion related to your endocrine disorders. We have covered it so far your diabetes mellitus, and we also discuss its complication, and we covered Cushing syndrome. This time we'll be talking about the rest of the endocrine disorders, which would be your Addison's disease, Pheocromocytoma, SIADH, and diabetes insipidus. It's not so long of a discussion. However, I think that would help you have a discussion, or a discussion over these diseases as you guide through your notes. So please be guided by the notes that identifies as your endocrine disorders, namely Addison's disease, Pheocromocytoma, SIADH, and diabetes insipidus. So let's talk about first with with Addison's disease. As I've said before, it's very easy for you to remember your endocrine disorders because it's just either too much or too little. So this time, Addison's disease is actually an adrenocortical insufficiency of all the three classes of adrenal corticosteroids that are produced or reduced. It is also an autoimmune response. So when we say there are three classes of adrenal deficiency of the three classes of adrenal corticotropic here are reduced or decreased, I want you to remember that your adrenal gland, specifically your cortex, which is actually the outer part, secretes your adrenal hormones called corticosteroids. And these hormones involve your glucocorticoids or your cortisol, which increase metabolism. It is also an anti-inflammatory and anti-glycemic hormone. Another hormone released by the cortex is your mineralocorticoid, exemplified by your aldosterone, which has the capability of retaining sodium as well as water retention as it excretes potassium. And the third hormone is your androgen, which is needed for sex characteristics, especially for male. Now, so these are the three main hormones that's affected here. In your Addison's disease, I want you to remember that it is the insufficiency of these three hormones. So it is also, as I've said, an autoimmune response. By the way, when we say autoimmune response, there could be a damage to the adrenal cortex done by the immune system of a person that actually leads to the decrease of production of these three hormones. So what are the different causes of Addison's disease? One, I've mentioned before, is your autoimmune. It can also be due to fungal infections. AIDS can lead to Addison's disease. And there are also cancer, certain types of cancer, and to mention iatrogenic. When we say iatrogenic, that goes also with the use of anticoagulant as well as anti-neoplasms. So, what are the clinical manifestations of Addison's disease? Oh, by the way, I also forget to add on removal of adrenal gland, or adrenalectomy would lead to decrease of this hormone, of course, obviously. So clinical manifestation. It is very important to remember that the clinical manifestation here in your Addison's disease does not come evident until about 9% or 90% of the adrenal cortex has been destroyed. So when the patient tries to manifest the symptoms, it's kind of late, or majority of the adrenal cortex has been destroyed already. Its primary feature would include progressive weakness. Well, if you remember progressive weakness, it's because your glucocorticoids would increase sugar in the body, which is needed for energy consumption. Well, obviously, there's a decrease of that hormone. That's why the patient would feel weak, fatigue. There will also be weight loss as well as anorexia. Now, I got to tell you too, that if we compare it with Cushing, which we already described, it's exactly the opposite here. We have a patient that's agitated and it's gaining weight and even have a buffalo hump. I'm just giving you now a comparison between too much or too little. In this case of Addison's, we are too little. Other features or other manifestation would include your skin pigmentation, especially that of the sun-exposed area, generally identified in the joint, pressure points, and palmar crease. Now, why do you think this happens? It's very important, you know. Well, if you remember, the adrenal gland responds to what we call as a tropic hormone, which is the adrenocorticotropic hormone released by the pituitary. Well, the pituitary as a master gland is also functioning in a negative feedback mechanism. If you remember, we talked about the negative feedback mechanism, that aside from secreting this hormone, it also is stimulating other hormones. So, in a negative feedback mechanism, when there's too little of your adrenal hormones, it sends message to the pituitary gland to stimulate the adrenocorticotropic hormone. But that negative feedback actually stimulates other hormone released by the pituitary gland. And that would involve now the release of your melanin, or it stimulates melanin release also. And if you remember your anatomy and physiology, melanin is a hormone responsible for skin pigmentation. Well, obviously, because of the negative feedback mechanism where the pituitary gland is being stimulated to stimulate the release of the adrenocorticotropic hormone, hopefully to stimulate the adrenal to release its own hormone, it also be stimulated to release the melanocytes. Therefore, that's the reason why there is increased skin pigmentation. Hypotension is another clinical manifestation, and this relates now to the decrease of sodium retention and water retention because of the lack of aldosterone. So as a result, the patient will have hypotension. There will be hyponatremia as there is a decrease of mineralocorticoid, especially that aldosterone that conserves sodium, and there will be hyperkalemia. And if you remember the relationship of aldosterone, where it's madly in love with sodium, and sodium is madly in love with water, but it kicks out. It kicks out potassium. In this case, there is no aldosterone. So sodium is not being retained, water is not being retained, but therefore, potassium is not being excreted out, but retained. As a result, there will be hyperkalemia. And that hyperkalemia would lead to arrhythmia and the tachycardia. Well, following with that, the patient will also experience nausea, vomiting, as well as diarrhea, all manifestation of your hyperkalemia, which, in a way, identifies an increase of peristaltic movement. So, complications of Addison's. Very important here is the Addisonian crisis. So how would we define Addisonian crisis? Addisonian crisis is an acute adrenal insufficiency. It is an acute case where there is too little or no at all adrenal insufficiency, which can be triggered by stress or sudden withdrawal of corticosteroid therapy. Let me pause here for a while. When we say triggered by stress, how does stress leads to Addisonian crisis? Where it's because when stress, remember, your body seems to react by fight or flight. But when stress comes in, might be emotional, physical, or perceived stress, there is a need to increase the fight or flight hormone, which your corticosteroid is one. But unfortunately, there is none or too little that it does not give you that energy release coming from increased sugar or glucose. So then the person will go into crisis. What about sudden withdrawal of corticosteroid therapy? How does it lead to the crisis? This follows the principle of your negative feedback mechanism. In the negative feedback mechanism, remember, when there's too much, the body would will not stimulate the pituitary gland to release the tropic hormone. So if the patient is receiving corticosteroid therapy exemplified by steroids such as your prednisone, well, there is constant corticosteroids that it does not stimulate the pituitary gland to release the corticotropic hormone or adrenal corticotropic hormone, because there is always a release of corticosteroids. But when that steroid is being stopped or halted, there is no enough time yet for the negative feedback mechanism to be activated. So therefore, there will be time that the artificial supply of corticosteroid from the steroids or from the prednisone is gone because of the sudden withdrawal, but yet there's no enough time for the pituitary gland to release adrenocorticotropic hormone to stimulate the adrenal gland. So then in that case, there will be the adrenal gland is not stimulated to produce its own, and thus a crisis will occur. Now, nursing care. That's the reason why, if you noticed, when you were in your clinical, you would see that a doctor would order steroids and there is always a tapering dose. That means one might be receiving, take 3 tablets of prednisone, and then 2 days after it becomes 2 days after it becomes 1, because the doctor here wants the negative feedback mechanism to be stimulated and take control naturally from the patient's system rather than creating a crisis. Okay? That's the reason why when you say that sudden withdrawal of corticosteroid. Additional crisis also may lead to extreme hypotension, as I explained before, because of the mineralocorticoid that's absent, tachycardia due to increase of potassium, dehydration because there's no water retention, hyponatremia, hyperkalemia, hypoglycemia, fever because of dehydration, the weakness due to hypoglycemia, and confusion. This all leads to the crisis. Remember that the brain needs glucose, and it's very important for the brain. So with hypokalemia, with hypotension, it may go into crisis, coma, that may lead to death. So that's very, very important in this as a complication. So what will be our collaborative care? Well, collaborative care would involve daily corticosteroid replacement. 2/3 on awaking in the morning and 1/3 late in the afternoon. So why do you think majority of the glucocorticoid replacement is more during in the morning or upon awakening and less during at night? Well, obviously for the reason that there's more activity during the day. So you need more energy and you need more glucose in that matter. Shock management also is a management. So when I say shock management, it's because there is hypotension and dehydration. So therefore, it also involves fluid replacement, and it may involve large volume of saline solution. And again, because we want to prevent shock. There could also be replacement of mineralocorticoids done once in the morning. So what will be our nursing therapeutic or acute intervention? Vital signs is very important. Vital signs, so we take vital signs in acute intervention. Since the problem is fluid volume deficit and there will be also electrolyte problems, we would like to assess vital signs every 30 minutes to every 4 hours for the first 24 hours. Daily weight, corticosteroid administration, and we would like to protect the patient against exposure to infection. Remember, infection is a source of stress that may lead to a crisis. So we would like to make sure that we protect against exposure to infection, noise, and also stress brought about by the environment, such as extreme light and extreme temperature, because the patient don't have a defense to deal with this. And make sure you stress out to have them follow up their appointment. On the time when the patient is to be released back to home or ambulatory care, we would like to teach the patient the importance of lifelong replacement therapy. I would like to stress this out. Lifelong replacement therapy. Teach additional exogenous corticosteroid adjustment secondary to stress. So that means we would like to make sure we teach the patient how to administer corticosteroid in times of stress. So what are these stress, or what are some of our guidelines? We may teach them to double the dose when minus stress occur. So what would be considered minus stress, such as infection, emotional stress? They can double the dose of their corticosteroid. Now, another thing is they could triple even the dose for major stress. And what are these major stress? Such as major injury, surgery, or even death of loved ones. You know, one principle here, it's better to err on the side of over replacement than under replacement, because it may lead to your crisis. The patient should also be taught to carry on a medic alert, as well as fluid replacement is needed. And also, the patient in this case may carry an emergency kit. And that emergency kit will probably contain a 100 milligram IM hydrocortisone in a syringe. Very important. That's an NCLEX favorite thoughts or concept. Well, why this? Because then when they carry a medic alert and they lose consciousness and there is this medication available, somebody else can give it, and that will save life. I hope it's clear at this point, for I will continue with another disease process of your endocrine, and this time is your Pheocromocytoma. You want to see that the name in there. I think it's in the second slide. Anyway, Pheocromocytoma, Pheocromocytoma. It is a rare condition characterized by tumor of the adrenal medulla that produce excessive catecholamines. Okay, if you remember, this time we will be talking about your medulla. Medulla is the middle or inner portion of your adrenal gland, which secretes catecholamines, or we call them neurotransmitter, which is also essential for stress. And what are these neurotransmitter? I think I've introduced it to yourself. I mean, I think I introduced it to you already before, and I called it, I just made it up, END, or your end hormones. When I put end, that means when life is threatened to its end, END are the hormone being released to counteract and hopefully maintain survival. And that would be your epinephrine, norepinephrine, and your dopamine. So those are your catecholamines. So in this case, it's a rare condition characterized by a tumor of the adrenal medulla that produce too much. So now, it's easy again to remember. What are the effects of your epinephrine? It increases blood pressure. It increases vascular resistance or contraction. So therefore, you know, you could see hypertension here. You know, when you have too much, you have your norepinephrine and your dopamine also are being increased. So as a result of an excessive catecholamines, it would lead to severe hypertension. Now, the clinical manifestation here involves severe hypertension, although the one here that has an asterisk, if you look at my cursor here, yes, pointing out the asterisk, these are now your triad symptoms, which is actually your severe pounding headache, tachycardia with profuse sweating. Okay, that is your triad symptom of your pheocromocytoma. Other manifestation would also involve anxiety. Patient also becomes very anxious, and there will be palpitation. And if you notice, all these symptoms are effects of your catecholamine increase, specifically your epinephrine. So what will be our nursing care and our collaborative management? Well, if the number one cause here is the tumor, then surgical removal of the tumor is necessary. That if it is applicable for your patient, unless it's contraindicated. So the doctor would probably remove the tumor of the adrenal gland. So removal, remember, the removal here is that it involves surgery, and surgery is also stress. So there has to be something done to decrease the release of these hormones prior to surgery. So preoperatively, we would like to block the sympathetic nervous system by using blocking agent, or by using sympathetic blocking agent, because now the patient is anticipating stress or surgery, they get more stress, then it releases more of this hormone. Then you go into hyper tension that's uncontrolled. So you like to give some blocking agent, especially that of Cardura or Menipres. This is to decrease the symptoms of catecholamine excess. And in this case though, we would like to monitor orthostatic hypotension specifically, because it can create also the opposite effect. Another medication that can be used here is your metyrosine. Metyrosine is administered to diminish catecholamine production. That if surgery is not an option. And this may even cause more hypotension for you if it's given, or for your patient if it's given. So you gotta make sure you monitor, you teach the patient what are the signs of hypotension, teach the patient how to stand up slowly while on this medication, that they need to stay, get out of the bed slowly from laying to sitting, dangle their leg about 5 to 10 minutes before standing up. Okay, so safety also is very important here. And then, as I have said, teach the patient to monitor the triad symptom, which is your severe headache, tachycardia, and profuse sweating. And then also emotional support for their patient. Remember, this patient is anxious, so give some emotional support. We will go now discussing about your disorder that's associated with antidiuretic hormone secretions. Well, remember, so there are certain disorders here, 2 disorders that's actually covered that involves antidiuretic hormone secretions. Remember, your ADH is produced in the hypothalamus, so, transported and is stored in the posterior pituitary gland. Okay, and how does ADH work? Again, ADH, antidiuretic hormone, its target gland is the renal tubules, where it prevents diuresis. So therefore, it retains water. Antidiuretic hormone. It actually involves water reabsorption, or prevention from losing too much in the body. So that's how the ADH works. Obviously, when there's too much ADH or too little, then it would lead to a big problem now. And this disorder may involve your SIADH, which is your syndrome of inappropriate antidiuretic hormone. In this case, in syndrome of antidiuretic hormone, syndrome of inappropriate antidiuretic hormone, there is overproduction of antidiuretic hormone. In the other end, there is also a disease process called diabetes insipidus. So remember, when we were talking with your diabetes mellitus, we were using the word diabetes, which pertains to urine. It's just that in diabetes mellitus, it's a sweet urine, and I told you my story about that. Now this time here, it's diabetes insipidus, but it involves the urine secretion, but beyond, on the back of it, it's because of an underproduction or under secretion of your antidiuretic hormone. So what would happen? If there's less antidiuretic hormone, there is large volume of fluid or urine being excreted out. So that's a big picture here of the too much or too little. So let's take up them individually. Let's start with SIADH. SIADH, as I've said, occurs when ADH or antidiuretic hormone is released despite a normal or low plasma osmolality. Normal or low plasma. Remember, if your blood plasma is high in osmolarity, the body wants to dilute. So, in order to dilute a high osmolality in the plasma or a concentrated plasma, ADH goes to the renal tubule, sequester or retained water, so that water will dilute a high osmolarity plasma or highly concentrated plasma. But, of course, with a low plasma osmolarity or a diluted, it should stop normally through negative feedback mechanism the ADH release. But in this case, where it is a disorder, even if there's normal or low plasma osmolarity, or I would say normal or a diluted plasma, ADH is still being released. So therefore, it is characterized by fluid retention. Fluid is being retained, therefore serum hypoosmolarity would result. There will also be delusional hyponatremia. There will also be hypochloronemia. But because there's too much of antidiuretic hormone, fluid is being retained in the body. So therefore, it will produce a concentrated urine. It will produce a concentrated urine in the presence of normal or increased intravascular volume and normal renal function. It's very important that you have to know that this problem is not due to impaired renal function, but rather due to the hormone. So what is the cause here of your SIADH? One is a malignant tumor that can produce or store as well as release ADH. Tumor that can produce or release ADH, malignant tumor. Another cause can be CNS disorder, which can be brought about by CVA or head injury. Patient who have stroke or patient who have even head injury, motor vehicular accident, or trauma to the head, usually will have some problem with ADH secretion. Other cause would involve also drugs or medications that can lead to release of more ADH, and this may involve Tegretol, diabinase, opioids, thiazide, tricyclic antidepressants. This may cause SIADH too. So what are the clinical manifestations here? It is characterized mainly by extracellular volume expansion, or there will be water retention or fluid retention. So when you have more water being retained, it increases the volume, but yet it declines the plasma concentration. That's why it leads to plasma, it has to be an S, plasma osmolality declines, or it becomes more diluted. Glomerular filtration rate may increase. There will be delusional hyponatremia. So when we say delusional hyponatremia, that means normally there will be normal amount of sodium, but because there is too much water, it was diluted to create a lower laboratory value. The urine output, there will be low urine output, There will be low urine output secondary to water retention, and therefore water is being retained, so then there will also be increased body weight. You could see also the increased body weight. By the way, let me go back here and we say glomerular filtration rate is increased. This is in the case of the filtration. But remember, that doesn't mean that when the glomerular filtration rate increase, it always lead to increase of urine output. No. In this case, it increased the filtration, but then, remember, your ADH goes to the tubule and it sequesters it and it reabsorbs it. So as a result, there's less output at the end. Where we're at. Okay. The patient will also experience vomiting, abdominal cramps, muscle twitching, and seizure, which is due to electrolyte imbalance, such as hyponatremia, hyperkalemia. There will be cerebral edema, lethargy, anorexia, and confusion. The cerebral edema is secondary to water retention. And then patient will become lethargic, anorexic, and then confused. And the patient furthermore may even develop, may complain of having severe headache, seizure, and coma. So what will be our collaborative care? The goal here is to restore normal fluid volume, osmolarity, or concentration. So therefore, if the body is retaining too much, then we would like to restrict fluid intake to about 800 to 1,000 ml a day. Note that this has to be divided in 24-hour shift or period. So whatever your facility will be doing, 8-hour shift, 3 shifts a day, or 12 hours a shift, or 2 shifts a day. The patient also may receive IV, but the characteristic here is that of a hypertonic solution, because remember, the body fluid is hypotonic because of water dilution. So then there will be hypertonic solution to be given, but if so, it has to be administered very slowly via pump. Remember, the problem here is not to replace. There is too much fluid, but the problem here is to concentrate. So, because the blood is already diluted, we would like to have some hypertonic solution to concentrate. And then the patient will benefit from Lasix. This is to produce diuresis so that extra fluid will be excreted out from the system. So what will be our nursing therapeutics here, or nursing responsibilities? You would like to assess vital signs, I&O, daily weight, level of consciousness, signs and symptoms of hyponatremia, and very important is your cardiac assessment. Why? Because in this case, the patient may have congestion, may lead to CHF, it may even lead to pulmonary edema and pulmonary congestion because of water retention. That's the reason why you gotta monitor your vital signs. We like to continue restrict fluid intake to not more than 1,000 ml a day, which would include even medication. And we like to position the position of bed flat or no more than 10 degrees elevation. I would like you to think that part there. Position of the bed flat or no more than 10-degree elevation. Think first before I do discuss. Why do you think? See, we have a patient who is retaining fluid, and why are we letting the patient lay flat on bed? Or if we have to elevate, we should not elevate it higher. Think. Try to think about yourself before I will continue. Okay. If you haven't thought about it, the scenario here, you have a patient that is retaining fluid, but yet we would like them to be flat on bed or slightly only elevated. Why? If you remember, the body fluid is also regulated by receptors in the body. Receptors in the body is located in the major blood vessel. Noteworthy is your aorta and even so your vena cava. Vena cava, which is, superior and inferior vena cava. Specifically the inferior vena cava. As the blood passes through, that osmoreceptor would identify, and baroreceptor, even the volume, you know. So what would happen? Think about it. If you constantly let the blood or that receptor, osmoreceptor or your baroreceptor, feel that there is lack of volume exemplified by elevating the head. So what would happen if you elevate the head too much or you put the patient up in an upright position? By dependency, by gravity, fluid tends to pull down. What happens to the pressure in the inferior vena cava? It becomes less. So it may sense the receptor that there is less volume. What do you think happened? With the negative feedback mechanism, it sends message now to your hypothalamus to say, hey, we need to release ADH because we need to retain water so that we increase the volume. Now it doesn't solve the problem because then you have more water retention. By keeping the patient flat on bed or at least not more than 10-degree elevation, there is constant elevation of pressure in the receptors, specifically in the vena cava, so that it does not signal the negative feedback mechanism to release more ADH. I'll give you a little time, process that discussion. Okay, I hope you were able to process that. It's very important. Other nursing responsibility is seizure precaution, and this seizure precaution can be brought about by the hyponatremia. That's why the patient may be prone to seizure. And another thing is, why do you think the patient here has to use a hard candy? And it says to decrease thirst. Where is thirst coming from? We have a body that is retaining fluid due to fluid retention, secondary to antidiuretic hormone secretion. But see, we're saying the patient is thirst. The thirst here comes with the restriction of fluid. Because you have a patient here that is restricted with fluid, chances are the patient is so thirsty, and to alleviate that nursing diagnosis, alteration in comfort, thirsts. So therefore, then we could let the patient suck on hard candy. And due to the delusional hyponatremia, the patient may need some supplement, dietary supplement with sodium. The last disease process. This time, we will be talking of your diabetes insipidus. So exactly the opposite of your SIADH will be too much of your ADH secretion. It is a group of conditions associated with a deficiency or production of secretion. Oh, I'm sorry, not too much. Deficiency. Too much urine is what I mean. But in this case, what's the pathophysiology behind is the lack of the production of ADH or the decrease in renal response to ADH. As a result, it may lead to too much output. And this is the too much that I said earlier. It will lead to increased renal output and increase plasma osmolarity. Because there's too much fluid going out, the blood plasma becomes concentrated. So what will be the clinical manifestation of your diabetes insipidus? There will be polydipsia, of course, because we're losing volume of fluid here. And there will be polyuria. It becomes too much that there will be 5 to 20 liters of fluid a day being lost. I would like to pause there. It says polyuria. Great. You know what polyuria is. And you may be probably impressed that it's 5 to 20 liters a day. But why did I pause? Because a lot of your examination, even your NCLEX, would lead and build up on that statement. Why? When you say polyuria and you have that much, you increase problem when it comes to safety. You have here the patient who will constantly go to the restroom. You have a patient that even at night when it's dark has to go and pee because of polyuria. So what I'm saying is have a three-dimensional way of thinking. It's not more than just knowing the volume. It's knowing the effect also. That this patient has to go to the restroom. So make sure they will not skid. They will wear non-skid shoes. They will have night light. That you have to remove. You have to remove objects that they may pass by, especially at night. You have to think about hypotension or orthostatic hypotension. I mean, those are the things that comes up with just that clinical manifestation, as well as to mean in your nursing care. Okay? There will be very low specific gravity. Urine is diluted. The blood has an elevated osmolarity or concentrated, as I've mentioned before. This is due to pure water loss. As I've said, patient will have nocturia and will become weak. So therefore, there will be increased risk for safety concern. Due to the decrease of oxygen perfusion, the patient also will have hypovolemia. Patient will have weight loss. There will be constipation because of decreased fluid in the body. So patient will have constipation. Of course, there will be poor skin turgor brought about by dehydration, hypotension I mentioned, tachycardia as a result of the decreased blood volume, and the heart tends to compensate. So this is a compensation mechanism due to decreased blood volume. And then ultimately the patient will have shock or hypovolemic shock. So what will be our collaborative care? The goal is to maintain fluid and electrolyte imbalance. Maintain fluid and electrolyte balance. So we would like to have hormonal replacement. And how do we do this? Hormonal replacement, this can be done by replacing hormone for antidiuretic that's given the patient dimoprisin or dimoprisin acetate. What's unique in this medication is it can be given oral, IV, or nasal. Patient, because there is hypotonic, there is hypertonicity in the blood plasma, the patient can receive hypotonic saline administration in order to dilute the blood. And drugs that can help to stimulate or correct the action of ADH may involve buprenorphine, diaped, Addison, Tegretol, and diabinase. Those drugs are given to stimulate or correct the action of ADH. And make sure the patient's sodium intake no more than 3 grams a day. Sodium intake no more than 3 grams a day. So what will be our nursing care? You like to maintain adequate PO and IV hydration as indicated. You like to monitor urine for glucose. Why? Because if there is glucose in the urine, it may create more osmotic effect. So it attracts more fluid, therefore it makes the polyuria more severe and leaves the body more dehydrated. So you got to be very careful that if you give IV glucose, it may create the problem of more water loss. And make sure you continue to do I&O monitoring and remember your patient's safety. That should conclude all the disease process that will be covered for your the remaining of your endocrine disorder. Thank you.